Okay, I would like to introduce our next speaker who is going to discuss the surgical management of melanoma, Dr. Russell Berman, who is an assistant professor in the Department of Surgery. Please welcome Dr. Berman.
Thank you, Rachel, and thank you, everybody, for inviting me to speak. I am a surgical oncologist with a specialty interest in melanoma and some of the more unusual cancers that Dr. Hell alluded to as well. But I'm also very passionate about melanoma, and that will be the focus of my talk. Now, as a surgical oncologist, I get asked all sorts of questions, beginning with what exactly is a surgical oncologist, to why, in fact, do I need so many doctors to follow me for a skin cancer. Once in a while, I get questions about surgery as well. But in addition to my talk, I will add some practical information that I feel will be helpful as well. So what I'm going to discuss includes, in fact, what is a surgical oncologist, your biopsy report after you see the dermatologist and they give you a biopsy report, surgical treatment, which includes local, regional, which is lymphatic, and the rest of the body. Now, not everybody who has melanoma will need more than just the local treatment. And as Dr. Hale alluded to, the earlier you find this, the less surgery you need, the better your prognosis. So honestly, the best skin cancers are the ones that I never get to see because they're treated in Dr. Hale's office and never have to make it to me or Dr. Pavlik. And also the multidisciplinary model of melanoma and long-term follow-up with these doctors. So what exactly is a surgical oncologist? Why did I double the amount of my training compared to a general surgeon? So it's a fully trained surgeon who has an emphasis on patients with cancer. And we have our own separate society. In fact, we're in the process of possibly eventually getting our own separate certification and recognition as a subspecialty. I like to personally think of us as oncologists who specialize in surgery as opposed to surgeons who then go on to train more in oncology. We really focus on understanding the disease biology. We are not dermatologists or dermatologic surgeons. They have a different set of responsibilities in the patient with melanomas and skin cancers. And more importantly to everyone here is we're usually the first people that the average patient sees after they're given the diagnosis of melanoma by their dermatologist. So as I mentioned, there are 3 levels of assessment, consideration, and treatment for patients with melanoma. The primary site, which is where the melanoma grew, the regional, which usually includes most commonly lymph node metastasis, or lymph nodes, and then systemic, which is really the rest of the body, every other organ in the body. And I'll be focusing mostly on the first 2, which is local treatment and regional. Now again, the hope is to catch us at an early stage so that most people's treatment never needs to go beyond the local level. But typically what we do is what's called a wide local excision. I'll explain that more in a minute. Again, at the regional level, that usually involves the lymphatics, and I'll talk about what's been going on over the last decade in that just a bit in terms of trying to reduce the potential wound complications with that and other complications. In other words, sentinel node biopsy, which a lot of people hear about. But just to step back 1 minute, I want to talk a little bit about the biopsy report. So after you get the biopsy by your dermatologist, you get given the diagnosis, which is, I'm thankful that the dermatologists have to do that, but you get given the diagnosis and then you get handed a pathology report, and that usually comes with you to the doctor's office. But what's important to note in that pathology report, and how do you know you've in fact gotten a good pathology report? Because it's usually not your dermatologist who reads that report, it's a separate pathologist. Well, just like I had specialty training in cancer surgery, pathologists will often go on to have subspecialty training in skin pathology as a specialty, and that's called the dermatopathologist. And what we like to see is that your report was read by, in fact, a dermatopathologist, that it's not somebody who's seeing colons and gallbladders all day and then gets thrown a slide just for skin cancer once every week or once every other week, that this is their specialty. So in fact, if I see a pathology report that's not reviewed by a dermatopathologist, I will in fact have it reviewed by our own or another dermatopathologist. What means in terms of treatment? What do we look for? What will determine surgical intervention, what will be our margins, and whether or not you're going to be offered a sentinel node biopsy comes out of that pathology report. And I'll go through some of those factors in a minute. It's also important because it does help us in determining prognosis. It's not the final statement about prognosis because prognosis and staging includes different various things, but it's amongst the most important. Again, it also helps with tumor staging and also helps us determine who we think would be of benefit for clinical trials. So this is the first thing that we look for in a melanoma pathology report, which is the thickness, as Dr. Hale alluded to. And with melanoma, although the diameter may help us in terms of diagnosing a melanoma, it's the thickness that counts. That's what's important prognostically, in terms of determining treatment, et cetera. And this just shows you, we're talking in fractions of millimeters. So we're not talking a large amount. We're talking a tiny, tiny, measured by rulers. And that's why it's so important to have a person who is trained in reading this as a skin pathologist, because there could be a big difference between fractions of millimeters. Then there's some other things, and Clark's level of invasion has traditionally been considered a very important prognostic variable. In fact, when it was first described 50 years ago, it was actually the first realization that how deep the melanoma goes into the skin carries prognostic significance. Before that, all melanomas were treated exactly the same. However, as we've developed more understanding of the disease biology of melanoma, this hasn't been quite as important and has somewhat fallen down as really a proxy for thickness. So as we look at this, it's not the most important factor. And obviously what this shows is that as the melanoma gets into the thicker levels of the skin, the risk for it having access to the blood vessels and lymphatics that really typically start around here increase and therefore have a greater risk. Ulceration is something that when I'm trying to assess the presence of this, I will ask the patient, did this bleed, or was it severely itching that made you scratch it and then it bled? And if that happens, that's called ulceration. This would be a melanoma on the surface of the skin that doesn't have ulceration, and here you can see it looks like a little crater, and that's ulceration. And when that happens, we know that it does raise our concern about the aggressiveness of that tumor. Not a tremendous amount, but it does upstage it a little bit in our mind, that it helps us, that information helps us make some recommendations. A mitotic rate is the most recent factor that actually has made it to the new staging manual for melanoma and is tremendously important. And if you go to see people who aren't necessarily up on the latest information, they may not consider this, but this actually carries significant influence in terms of the management of melanoma. If you think back to your science courses, you heard about the cells and they split. And when they're under the microscope and they're about to split, as their DNA doubles, you can see what we call mitotic figures under a microscope. What it really is a reflection of how fast that tumor is dividing or rapidly growing, usually in the vertical dimension for melanoma. So it really gives us an insight into the aggressive biology of the melanoma that's at hand. So that's critically important for a dermatopathology report. And since really it's just become a part of the official staging this past January, a lot of people have not yet included it. So again, if I see a pathology report where that's not assessed, I will send it to our pathologist to specifically get what is the mitotic rate on this. So now let's talk about the treatment. And again, what's common amongst all patients of all stages of melanoma is that they need it excised with a wider margin because it doesn't follow rules of going straight down into the skin in a straight line. So we need to take a wider margin around it to get any stray cells that may be out on the sides or deeper. So what the mainstay of treatment is called a wide local excision. There are some people who refer to it as a wide and deep excision as well. But what are the goals of this? It's to surgically eradicate all tumor cells, and that's a primary reason to do this. But to keep things in mind, we do try to minimize morbidity. We try to minimize the functional impairment of where we're operating, because it's on all surfaces of the body, and minimize disfigurement, because again, this could be on the face, on the eyelid, or just about anywhere. Now, taking a step back to a little over 100 years ago, Again, that was a time when melanomas really were treated all the same. There was no recognition that the thicker the melanoma, the worse the prognosis. So radical surgery was done for everybody. And this is taken out of a textbook, and I won't necessarily read the whole thing, but basically the skin's taken with the layer of subcutaneous fat all the way down to the fascia, which is a covering of the muscle, and then with a big scoop out of all the muscle underneath it. And then if that's not enough, all of the lymphatics in the area are removed along with that. So that means that every single patient had a radical procedure that required skin grafting, because you could never close something this size, and removal of the lymphatics with all the potential morbidity involved in that, even if they have what by today's standards would be a simple wide local excision in the dermatologist's office. So I like to think that we've made some progress in the 100 years, and hopefully who's ever standing in this lecture hall 100 years from now giving this lecture will, kind of chuckle at we're doing now, thinking about how backwards we are at this stage. But we have made progress, and we've done this through clinical trials. And there have been 5 major clinical trials and international trials looking at what is the appropriate margin to take. Again, the standard before the 1950s and 60s was a 5-centimeter margin. That's 2.5 inches all the way around the biopsy site or the pigmented lesion, all the way around circumferentially. So that is a huge amount of skin to remove from somebody's body. And I'm not going to go through the details of it because typically different thicknesses were used and different margins were used. So it takes a lot of statistical manipulations to try to figure out what to get out of this. But the summary, which I will go over, is kind of as follows. If your melanoma is 1 millimeter thick or less, so again, we're talking a tiny, tiny fractions here, then we know that a 1 centimeter margin is appropriate. So that's, a quarter of an inch or so. If it's between, let's skip over the 1 to 2 because that's still a little controversial. If it's greater than 2 millimeters, we know that you need at least a 2 centimeter margin, a little under an inch, taken all the way around. And if it's between 1 and 2 millimeters thick, then you need between a 1 and 2 centimeter margin. And I usually use my determination based on where that is. If it's on the face or on a finger, then I will default to the lower margin, where if it's on a place with excess skin where it's not as cosmetically disfiguring, I'll go ahead and take the 2 centimeter margin. But either way, what you can see here is that we've been able to drop down the margins from the original 5 centimeter margin, and with those studies prove that we don't decrease survival, we don't decrease recurrence when it's done correctly, and we certainly can improve quality of life, decrease morbidity, decrease disfigurement, etc. Now, this just looks at some examples of wide local excisions. So here, this is a excisional biopsy scar, and this is approximately a 2 centimeter margin drawn around it. Then, just by skin dynamics alone, you can't close an oval or a circle of skin because the edges will fold up and out of you, which we don't want to do. That's cosmetically unacceptable. So we have to make it more or less into an ellipse, which also could look a little bit like those hurricane things that you see on the weather maps as well. Some people say it looks like an eye, and my residents call it the Berman eye. But that's what we have to excise. And with anything else with skin, when you excise it in somebody with good skin, that opening expands. And so you actually have a fair bit of skin to cover there. Most of the time, we can do that without needing a skin graft in most areas of the body. And this shows a type of closure with stitches that need to come out in the office. But depending on the tension, we could also, and we try to use dissolvable stitches as well. In the face, obviously, it gets a little bit more sensitive in terms of cosmetics. And, well, let me go up one. Here, you can see the lesion right here by the chin. Now, that's not a bad place to have it. And this is a primary closure. In other words, no fancy plastic surgery flaps were needed. But obviously, again, it's a longer incision than you would expect. And it looks terrible right now. But as you go on, you'll see that it heals remarkably well, especially in the face. So again, decreasing morbidity, decreasing disfigurement, and increasing functionality is our goal. This is a relatively large but usually thin melanoma in a not very good location. And for this, because it's so broad, just trying to pull the skin edges together isn't sufficient. So we have to do what's a flap, and that's based on this. This is a typical facelift incision place because it's hidden by the ear. And we're going to move all of this skin over to fill in that defect. It looks a bit graphic now. Because again, we're going to flip this whole pedicle of skin over here to fill in the defect. And it looks pretty horrible in the very early postoperative period. But if you look down the line, it heals remarkably well. So again, we're not just looking to remove the cancer cells, we're looking to do that with the most minimal impact upon your life. Now let's go to the next stage, which is the nodal staging. So again, if it's very thin melanomas, then we don't typically have to assess the nodes in anything more than a physical exam. But once it gets a little bit thicker, we have to consider that there is a reasonable chance that there could be nodal involvement. Now, as you know, up to the last 10, 15 years, our only option was really to feel the lymph nodes on exam. If the lymph nodes were enlarged, we confirmed that there was melanoma in there, and we did a full lymph node dissection. If they weren't enlarged, you really had a choice. Either remove the lymph nodes up front to see if there's any microscopic cells in there, or just ride it out and get exams every once in a while, and if you develop nodal disease, then you go ahead and remove it. So if you had the nodes removed when you develop disease, that's called a therapeutic node dissection, or TLND. And if you just removed them when you showed up to the office and you had surgery and you removed them and you were looking to see if there's microscopic cells, that's called an elective nodal dissection. Those were your only choices. Now, the problem was that only 20% of patients with melanomas greater than a millimeter thick had microscopic cells on the elective nodal dissection. So you're doing a very morbid, very large operation where 80% of the patients had no chance at benefit whatsoever from doing that additional procedure. So that wasn't very satisfying. And decades of controversy existed around this. Is it worth putting through all, 80% of patients through what's going to be a negative procedure if that will help the 20% who do have positive nodes? And 4 major studies have looked at this, and honestly, in those studies, when you look at all patients involved in the studies, there was not a survival advantage to doing that elective nodal dissection. So really, very few people wanted to put somebody through the extensive morbidity and complications of a full nodal dissection when we didn't think we could truly impact upon the survival of the overwhelming number of people who would get that procedure. But we do believe to this day that there's a small subset of people who will benefit from that. So the question came up is, can we go ahead and find who has microscopic disease in nodes without all of the potential complications of doing a full node dissection? I kind of went through. And the reason why, of course, is because doing a full lymph node dissection does have significant impact upon quality of life. If you remove the lymph nodes under the arm for melanoma, lymphedema, which is a potentially permanent swelling of the arm, happens in up to 15% of patients. In the inguinal node dissection in the groin, that's up to 40% of patients who will have permanent swelling of their extremity. Not to mention the risk of nerve damage and other structural damage. So we don't want to put people through this if we don't have to. What we've developed over the last 20 years is something called the Sentinel node biopsy, which is very common and discussed out there in the literature, on the internet, et cetera. And this was proposed as a low morbidity alternative to elective node dissection under the premise that a primary melanoma will spread through the lymphatic channels to 1 or maybe 2 first nodes before they would go on to the other nodes in that area. And that we can go ahead and find and remove just those 1 or 2 nodes to see if there's any disease in there. If there is, then we would recommend removing the rest of the nodes, but if not, we're done and no more surgery is necessary, and there's a lot less morbidity to that and the risk of only 1 to 2%. So there's been one major study that's looked at this internationally, the MSLT, as listed there in the last bullet. And what this showed us was that it is a safe procedure. After a surgeon gets experience with it, the results are very accurate and very reproducible. What are the potential advantages of this? Well, we know that it selectively determines which people have cells in their lymph nodes that we should go on to do a full node dissection. It is the single best way to stage the lymph nodes in terms of determining prognosis. And also, it is certainly less invasive than the traditional lymph node dissection. When we look at it, it is the most important prognostic predictor of how the patient will do overall in terms of survival. It helps us determine who should go on to clinical trials or not. Question is, just like with the elective node dissection, does it improve survival? We have not been able to prove that it improves overall survival, but we know that it does improve melanoma-specific survival, meaning that it'll decrease the chance of it coming back in the lymph nodes, but we don't know if you'll live longer in the very long run compared to not having it done. That's still being worked on. So when do we offer a sentinel node biopsy to patients? Well, if you look at the top part there, we'll see that if you have a melanoma that's greater than 4 millimeters thick, you have a 35% risk of having nodal metastasis, or nodes in, melanoma cells in the nodes. If it's between 1 and 4 millimeters, what we consider an intermediate thickness melanoma, it's 20%, and less than a millimeter with no other of those ulceration or high mitotic rate things that I showed before, it's less than 5. So my indications for offering a sentinel node biopsy is if the melanoma is greater than or equal to 1 millimeter thick, or if it's less than a millimeter thick, in other words, a thin melanoma, but has these concerning features on the well-done dermatopathology report, as I mentioned before, ulceration, mitotic rate, Clark's level, and a few other features which we don't have time to go into. But this is my recommendations. It can change with other surgeons as well, but these are generally accepted criteria out there. And how is this done? We use a combination of blue dye that gets taken up by the lymphatic channels, as well as a tiny touch of radioactive dye. We inject it at the time of surgery around the biopsy site or around the melanoma. And this is a lymph node basin, and we can follow, it doesn't project well, but there's a lymphatic channel that's blue that goes to a lymph node that's stained blue, and we also check with a handheld Geiger counter that it's radioactive. That's how we know which nodes to remove at the time of surgery, and then the pathologists check these very carefully. Now, just one word of practical advice. For patients of mine who get sentinel node biopsy, depending on where it's located, we may need to get a preoperative nuclear medicine test which actually traces the lymphatic drainage from where the tumor was growing. It's called the Lymphoscintigraphy, and it tells us, for example, on the trunk or in the head and neck, which lymph nodes that area goes to, because it can go to the armpits, the neck, the groin, etc., or multiple places. This is a picture of, here's the primary melanoma that has drainage to both armpits. However, I frequently get patients who call me up after the lymphoscintigraphy that say, they mark 2 lymph nodes. That means I have cancer in the lymph nodes, right? The answer is no. This is purely providing us with an anatomic roadmap of where we need to remove on the lymph nodes on the day of surgery. It says nothing about whether or not there's metastatic melanoma in there. We don't know that typically until after the pathologists get to review the lymph nodes after surgery. So it's just a practical point. Now, just a quick note, there are some people who have more advanced regional disease, disease that involves usually little nodules either on the skin or below the skin, either around where the melanoma grew or going up the leg or the arm or even on the trunk. So those are called satellite or in-transit metastases. And again, these are intralymphatic metastases, in other words, little emboli of tumor cells, either within the skin or the subcutaneous lymphatics that sit between where the melanoma grew and where the lymph nodes drain that area. Whether you call it satellite or in-transits really aren't important. They represent the same biology and really carry significance along the lines of nodal disease. And how do we go about treating this? This gets a little bit more complicated because often there are many. And so local therapy, just cutting out individual ones, is associated with a high rate of local failure. They grow in different places or they can come back. So really what we'd like to do is give chemotherapy or other agents directly to the entire extremity. But that can get, if you give too much chemotherapy, then the patients could get very sick from the chemotherapy. So we've developed what's called regional deliverance of chemotherapy, either through isolated limb perfusion or isolated limb infusion. In other words, through vascular means of occluding the vessels that drain the arm or the leg, we're able to deliver a very high dose of chemotherapy or other agents into the arm or leg that really give a very intense concentration of chemotherapy and other agents to all of the tissues of that leg and allow us to diminish the amount of disease there. This just shows that this was actually first conceived of in the 50s when the cardiac bypass technology was coming through, and the machines that we use for the perfusions are still the same as what's used for bypasses for hearts. And the last bullet there just shows that Fred Gollum was an NYU surgeon who actually wrote about this as early as 1961. So we were on the cutting edge even then. This shows a very complicated isolated limb perfusion circuit. Not going through this, obviously. It's a very complex, very long operation that people who are older, people with vascular disease, people who can't tolerate 7 hours of surgery really don't benefit from. And even in younger patients or healthier patients, there's a very high complication rate to it. So what has been developed over the last 10 years or so is called isolated limb infusion, using many of the percutaneous techniques that we use now for cardiac catheterizations. And this came out of Australia, which has the highest incidence of melanoma in the world. John Thompson, who's a surgeon there. And it is very similar, and it may still look complicated here, but it's actually a much simpler operation. It takes around an hour and a half to do. You can do it multiple times because you're accessing it through a needle stick into the vessels as opposed to a full operation. Even people with calcified arteries and older patients can tolerate it well, and you can even potentially repeat it. So this has been a major advantage over the last few years. Now, I'm not going to go into this, and Dr. Pavlik's going to talk about more systemic or other organ disease. But under individualized circumstances in the right patients, surgeons are involved in removing disease in other organs in the body as well. This just shows one technique for destroying a liver tumor through heating it up, or microwave or radiofrequency ablation. So if, in fact, a person gets the news that there are very few or limited disease in other organs of the body, it doesn't mean the surgeon won't be involved. Now, this is my push for multidisciplinary melanoma care. And people always think that surgeons are arrogant and self-centered. So I won't comment that we're in different color and smack in the center of all the other doctors. But this shows where we have separate focuses and where we overlap. So the dermatologists, they're critical for detection. There's no question about that. Biopsy, but also, as Dr. Hale mentioned, for the earlier lesions, there's no reason why a dermatologist cannot remove them as long as they are used to that and that's within their scope of practice. The surgical oncologist overlaps in multiple areas, as I've gone through. Yes, occasionally I do get to see the thin melanomas, and that's always very gratifying. It's not my typical, but it is gratifying. Certainly dealing with the primary, nodal, and in-transit disease, as I already went through in my talk, but also resectable distant disease when there's a limited number. And then, as Anna Pavlik will come up, she overlaps with the resectable, more advanced disease, as well as that is not surgically resectable. There's one person who I left out, and if they're in the audience, they'll kill me if I don't put them in there. So the radiation oncologist. And it was widely accepted in the past that melanoma was not a radiosensitive tumor, and therefore there was no indication ever to use radiation therapy. That is not true, and under the right circumstances, they can be very helpful, and it's usually when it involves nodal or advanced nodal disease. So Sylvia's out there, that's my plug. Now, in terms of melanoma follow-up, it really is partially dependent on the extent of disease, which I think we've all mentioned to date. And each one of your physicians has a different focus. So your dermatologist doesn't replace your surgeon. I should certainly not be in charge of your skin screening, I could assure you that, and neither of us replace the medical oncologist. And I think this just to end. So the dermatologist certainly does full skin surveillance as well as looking at the site where I operated. There's no question about that. Surgical oncologist, again, looking at the primary side where we remove the tumor, the lymph node areas, and also trying to assess to see if we can find that there's disease that's spread to other organs that's pointing to the abdomen. And then the medical oncologist, which really looks at pretty much everything. Whenever Dr. Pavlik constantly scrutinizes everything from my incision to the lymph nodes and looks at the body as a whole. So it's really a team effort. And when people ask me, why do I have to see so many doctors in follow-up for my melanoma, it's because you're better off having the team approach. You're better off having the expertise at each different level that we consider critical to melanoma care. So thank you very much.